Hello everyone. Welcome to this event on the occasion of the World Health Summit. I'm Shuli Ghosh, and I'm delighted to be moderating this session on behalf of World Health Federation with the support of MSD. So the purpose of today's event is to explore pathways to prevent, detect, and manage cardiovascular disease in low and middle income countries, which of course is a huge priority given that CVD is the leading cause of death globally, and 4 in 5 of those deaths occur in LMICs. But despite those sobering statistics, CVD remains underfinanced and under-prioritized in health policies and planning, especially in low-income settings. So to tackle the growing burden of heart disease, countries are being urged to put in place a national cardiovascular action plan, basically a health strategy which is tailored to the national or local or regional context with quantifiable targets and simple cost-effective measures to reduce mortality rates from CVD, to improve treatment outcomes, and to promote healthier hearts. Now, it's hoped that these cardiovascular action plans will form one of the commitments of world leaders at next year's UN high-level meeting on NCDs. But right now, data from the World Heart Federation shows only 7% of countries have a standalone CVD plan, and those are mostly located in Europe and the Western Pacific regions. So our session today is going to focus on the specific challenges and the opportunities in implementing and scaling CVD action plans in developing countries, and explore how we can overcome some of those financial and infrastructural and political barriers. I'm delighted to say that I have an excellent panel of speakers and experts and stakeholders who are going to help us uncover some of those practical solutions to the challenges. So they're seated around me, so in no particular order, let me introduce them to you. Dr. Sophie Miller, EU Policy and Advocacy Manager of the European Society of Cardiology. Welcome. Dr. Lillian Mbao is next to Sophie, CEO of the Centre for Cardiovascular Prevention and Rehabilitation in Kenya. Magdalena Dacour, who is the CEO of FH Europe Foundation, which is a patient network for inherited lipid disorders, which of course are CVD risk factors. Dr. Gerald Mutunji, the Assistant Commissioner at the Department of NCD Prevention and Control at the Ministry of Health in Uganda, and Dr. Monique Bleder, Practice Manager for Global Health, Nutrition and Population at the World Bank. And I'm pleased to say all my speakers are going to take questions, so please do have those ready. And it doesn't even have to be questions, you know, it can be observations, anything you want to add to the discussion. So let us start with why standalone CVD plans are so important and what they should include. And so if we kick off with you, CVD action plans. Why are they so critical in providing a sort of framework? I'm guessing they're guiding national and regional strategy. Why is that important, and what has to be included to make that effective?
Thank you. I'll do my best to shout. So just if I'm too quiet, raise your hand. I'll try to shout. It doesn't matter. But thank you so much for the invitation to the meeting to be on this panel. It's a great honor to share the stage with my fellow panelists. I will start things off very simply to answer this question to begin with. So for me, nothing happens without a plan. What happens without a plan? So at its very essence, to have an action plan to tackle cardiovascular disease and improve cardiovascular health is the #1 step. It's the #1 building block. We need intentional action. We need specific action. We mentioned the stats that we're very familiar with, and this is nothing to be proud of, and it's not going to passively get better on its own. So that's not, it's the first thing to say very simply, that it's a straightforward ask that we need action plan for anything to happen. I'll also speaking here on behalf of EACH, which is the European Alliance for Cardiovascular Health. ESC is a member, FH Europe is a member. And we, in 2022, published our vision of an EU action plan. And here we have listed all items we think that need to be tackled from A to Z, starting with primary prevention, not only that, but also secondary prevention. We know that up to 80% of heart failure patients are only diagnosed once they reach hospital in Europe. This is of course far too late, so we need better early intervention, screening, diagnosis. To begin with, we need earlier and equal access to interventions, treatment, care, not only in the hospital, but also afterwards, rehabilitation, improving quality of life. And this needs to be, this is our foundation as we see on EU action.
So that's an EU-wide action plan.
Yeah.
Can I just play devil's advocate and ask you a little supplementary question? You said right at the beginning, a plan, we need a plan.
Yeah.
Why do we need a plan? Because why isn't cardiovascular health included as part of just general strategies for overall improved health?
Yeah, thanks for the question. So there are some NCD plans, generalized plans, and as I was talking to Lillian also just before the panel started, we see the trends from the last decade. We've been focusing on public health promotion for the last, let's say, 3 decades, and we don't see necessarily improvement. So the game has got to change. And here I think we need to start with specificity and to target items within the cardiovascular disease pathway that can really make a difference at the EU level. This is also on broader terms of having funding for research missions to understand better the basic science. And also for data registries, we need data to show what change is possible if policy is in place. And we know, as we said earlier in another panel, what gets measured gets done. So this is why putting this on paper to begin with is the first step. The next step is more difficult than turning it into action on the ground implementation.
That's always the crunch moment, isn't it? So European Alliance for Cardiovascular Health, each, as you say, ESC is part of that, the World Heart Federation part of that, I think Europe part of that. How's it going? I mean, what are the challenges to doing a whole EU-wide plan? It's challenging enough in one country, but doing a sort of pan-national one must be even more difficult.
Yeah, no, thanks for the question. We'll have to start somewhere. So I think as collectively, we're quite proud of each from the last few years, established in 2021. We're now 21 partners together representing patients, industry, healthcare professionals, and so forth. And the glue that brings us together is calling for this policy action.
Yeah.
And this doesn't come from nowhere. It is hard work. Collaboration is at the essence of everything that we do. And I think the first thing is being united as one voice, because it can be, as we in every country, every situation, there's a lot of people trying to get attention for topics, of course, and so we need to be loud together as one, as 21 partners and more. So improving our exposure, our visibility, we've really been working on that for the last couple of years. And now we see definitely better attention at EU municipal level, be it from the Parliament and the Commission. At the moment, it's a very sensitive time, let's say, because we are hoping that in the next few months that we see published, announced, dedicated action from the European Commission to be seen. So I touch wood still, it's not quite there, but we are being loud, we're being out there, so we hope this will have some measurable effect.
Yeah, I think being vocal and having that dialogue is absolutely key. And I will talk to you a little bit more about what's going on in Europe. Thank you very much indeed, Sophie, for kicking us off on that overview. Lillian, let me come to you. So that's the ideal situation that they are looking for in Europe. You have extensive cardiovascular experience in cardiovascular care and policy development. You work in Kenya. What would that look like? What does a CVD action plan look like in developing countries?
Thanks so much. I'm happy to be in this panel. I think it's good to understand the setting we are in. So most of our countries in Africa are still facing a double burden. So we have the communicable diseases and we still have the non-communicable diseases. So when you're doing a CBD action plan, you need to remember that we are all trying to eat from a very small funding pot. Because the governments are not putting enough money in health. Most of our countries are not yet achieving their Abuja declaration of 15% of the budget of a country expenditure towards health. So we have a shrinked budget and we have all these health demands, including maternal and child health issues. So I think it's good to understand the context we are working in. We also don't have the EU, we don't have a regional direction. In NCDs, I've not seen any regional initiatives trying to compel countries to address NCDs or CBDs.
There's no regional lines.
Yes, there's no regional wide.
So no alliance, like the European alliance that Sophie was talking about. You
Yeah,
don't
we have the regional bodies, but I've
Yeah.
not seen any strong push from the regional level for countries to put in place and to address NCDs specifically. So it's more a lot of it country specific country, yeah, individual countries doing their own kind of.
Because yes, I've noticed that individual countries, Uganda, Rwanda, Kenya are doing it, but that sort of regional overview aspect is missing.
There's no strong pressure.
So those are the challenges. What do you think of a standalone CBD plan as a cardiovascular expert?
So yeah, many countries in Africa have an NCD strategy in place. So some of the issues we face when trying to get our governments to have a CBD plan or strategy is we already have an NCD strategy. Why do we have to have another specific cardiovascular strategy? So we have to get into a situation where you justify the need for a CBD specific action plan. But again, because the burden is rising and the governments are seeing that CBD is having a huge burden, they are open. So like Kenya, our government in the initial discussion is open to having a CBD plan because they recognize that the burden is high and it's going to continue to rise.
Because presumably prevention and early detection would, in the long run, be a cost saving for long-term treatment and illnesses further down the line.
But let me add that a lot of our countries, and Michael here will talk about Uganda, we are focusing more on universal health coverage. There's a lot of focus. So again, that's why the country is looking at health holistically in a more integrated approach. So that's sort of how they are looking at how they want to reform the health sector and not disease specific, because we've had bad experiences with verticalization of programs in the HIV area, which came with huge funding, and then the funding disappeared, and now governments are having to put their own funding, which is important. But because we have some negative or that negative kind of impact of having vertical programs, there is that aversion towards disease-specific plans or programs.
Right.
So it's a balance between vertical programs versus universal health coverage. So that's the other tension that is going on.
Okay, I will come back to you and ask you about universal health coverage. I think that's quite an important factor. But for the moment, Lillian, thank you very much indeed. Magdalena, so we were talking earlier, and I know you're going to explain everything much better than I'm going to explain it. FH Europe, a network of patient groups across Europe for people who have a familial lipid disorder, a risk factor in CVD. Okay, so that's a very simplistic way of putting it. I'm aware of that. So please expand. Tell us about your work and about the importance of patient advocacy groups.
Again, thank you so much for the opportunity to be here because it's an important platform and hopefully important people who will contribute to the change. So FH Europe Foundation is one of patient groups that exists in the wider space of cardiovascular diseases. But we are trying, and we hopefully are distinguishing ourselves as a group that fights for not only patients, but also on behalf of citizens, because this is where health starts at the citizen level and a healthy person. FH stands in our case for familial hyperlipidemia. So let me break it down. It's a genetic risk factor runs in the family. If your mother or father has it, there are chances or risk that you will inherit it. Hyper means high lipid, and this could be cholesterol or any other lipids in the body. All lipids are very important. It's only when it's too many, too much, when it causes a risk. And the risk is inevitably cardiovascular disease in the form of premature heart attack or stroke. So I would like to expand that whatever we discuss, we take heart attacks and strokes into consideration. As I mentioned, those are familial. So once you have the first person in the family identified, by just cascade screening the family members, you will be able to identify other people at risk. And because they are genetic, they are from birth. Which means that we actually have an opportunity to turn the narrative around from cardiovascular disease, when we actually allow the heart attack or stroke or even premature death to happen, to, hold on a minute, cardiovascular health, where we detect it early and we implement an array of solutions that are not all costly to actually preserve that health and prevent the disaster to happen. So this is what we do. Under our umbrella, we have familial hypercholesterolemia. It is the most common genetic cardiovascular risk factor in the world. So prevalent and so poorly detected that actually it has a rare form, because in the absence of knowledge, people who have it don't know, and then very often when they have families and two people have FH, they might actually have offspring with the homozygous form. Just to put it into perspective, children with homozygous FH can die as early as first year of life as a result of atherosclerosis. Atherosclerosis is a buildup of cholesterol in your arteries, normally observed in people when they're 70. Imagine a child that has got an occlusion of 98% dying of a heart attack at the age of 1. Unacceptable in this day and age. As we are at the World Health Summit, the World Health Organization actually announced familial hypercholesterolemia a global public health burden, ladies and gentlemen, more than a quarter of a century ago. We have the knowledge, we have everything it takes to resolve it, but the needle hasn't moved yet. There is more to come though, because it turns out that there is another very important risk factor, so-called elevated lipoprotein A, that affects 1 in 5. I just counted when we were sitting, there are 23 people in this room. Potentially 5 of us here, sooner or later, will not talk about them patients, but as patients, because it will affect us.
That's quite a sobering thought, thank you. So, we're all thinking about getting tested. Slightly worried, thank you very much.
I don't
So obviously, we were talking to Sophie about the Europe-wide plan for CV, cardiovascular health action plan, which that would form part of. Can we turn that into a low income setting context? Can we take what's happening in Europe and apply it to a low income setting? How would that work?
It's a very difficult question because there is no one answer or perfect answer. And I think with that, I would like to emphasize the importance of no one size fits all. I think there are fundamentals. So there is science, there is data, there is evidence that we can use. And when I was talking about this 25 years we've known about issues, we haven't resolved them yet. There seems to be an element missing. What could that be? And we came to a conclusion as a community of patients, leaders of patient organizations, that maybe devil is in social sciences and behaviors. And I think this comes to the fact that we need to be very, very cognizant of local structures, religions, social formations. And I think we need to be very, very respectful that solutions need to be co-designed with the local community. So if we want to transplant some of the solutions, yes, we have the top level ideas, but then we need to be very, very respectful of what happens on the grass level. I could just throw an example. When you talk about patient in Italy, you will talk about someone who is affected in the Nordic country. That's just Europe. if you talk about, stopping to smoke, move more, and eat differently in Bulgaria, you're being looked at, as, you know, what are you coming with here? It's part of our culture and DNA. So I think if we talk about other countries, and it's not just Africa, I think it's not just lower and middle income countries, it's really taking into consideration.
Yeah, absolutely. Thank you very much indeed. We'll come back and talk more about that. Gerald, let me come to you. We've already heard a little bit about from Lillian about the competing priorities that we often see in African countries. In Uganda, you've got, I know, national plans in place for malaria, for HIV, for polio. As head of the NCD department, this must be very difficult to talk about CBDs. How do you develop, or what are the challenges in developing a strategy specific to cardiovascular disease?
Thank you very much, and thank you to WHA for inviting me. Unfortunately, it is true that cardiovascular diseases have not yet attracted the priority that they deserve because of what my sister has said, because of the other burden of communicable diseases. Actually, she called it double burden, but it's triple burden. So you do have maternal and childhood illnesses that are still battering. So again, NCDs are not part of the international health regulations. So you see where the priority comes from. Actually, we are handling national health regulations. And again, these are not transmissible diseases. So if you have your hypertension or diabetes, it's you alone. And then they care most about, imagine if there was Ebola, now we are battling Mpox. So that tends to take away the priority to those diseases from problem. But the other unfortunate thing, these diseases are commonly referred to as lifestyle. And when you say lifestyle, it means you have caused it yourself in a way. So let's first handle
That's the perception, isn't it? That it's a lifestyle.
That's
not the case.
That's true. Then after many cardiovascular diseases affecting Africa, not necessarily the lifestyle. You find very lean active people getting those conditions, but somehow the name is lifestyle. So is that brain component? But also we don't know why they have not attracted international funders come and fund NCD prevention and control. So these other action plans we are talking about for malaria, for HIV, immunization are funded by international partners. And therefore, they have asked for action. There are some indicators, they have to be reported on and all that. But nobody is interested in funding.
You've got big donors for you,
And I'm happy
but
to
not
have
the
the answer here.
NCD.
We'll answer some of these questions. So that is also another challenge that NCDs have not attracted international partners to fund these action plans.
Oh, well, that's interesting. We will talk to you about that. But that's, I mean, Gerald, you were saying that, you know, if someone's got an infectious disease, it spreads. But if someone's got an NCD, cardiovascular disease, it's seen as only affecting that one person. But that's not true. The burden of NCDs, it's affecting whole communities. So why is it not?
Yeah, that's
Why is
true.
hypertension not?
That's true, but the other thing is, non-communicable diseases or CBD are not dramatic. Imagine if you bring a child with pneumonia and find there's no medicine, that would be dramatic. The politicians will deal with you. If somebody comes with malaria and there are no medicine for malaria, the child may convulse. So that's the dramatic I'm talking about.
Yeah.
If somebody has hypertension or diabetes and not glad, we will walk home. Say, I'm sorry, I've not got a treatment. He may die home or he may develop complications later. But at that time when he comes there,
I see.
nobody, even the health worker, like in Uganda, the way we find the healthcare system is that each health facility is given resources, and that health facility must plan for those resources. When they are planning drugs, they make sure they have antibiotics, they make sure they have anti-malaria, because once they don't have, even the politicians will give them. But if no hypertension, the patient will come, they give you a prescription to go and buy. You will go back. In most cases, they don't buy because they don't have money. But it's not as dramatic as if somebody had pneumonia and went away.
And often, from others I've spoken to, even if you do pick up the prescription for hypertension, often people don't take them regularly or don't carry it on, they don't follow the treatment program. So with your, with your head of NCD department, what would be the value of a CDD plan for you? How would you want it in an ideal world?
Thank you. I would want it because my colleague had said, if you don't have a plan, then
Yes.
you're moving. But if you have a plan, you have actionable programs, you have indicators that you have to report on, then things move. Because even our health workers down in the health facility, we have to report on those indicators. We want to follow up. But now there is no plan. They will report on HIV, on malaria, because somebody is following them up. Because for HIV now, they are looking at numbers, 95, they must report whether we have identified those with HIV, whether we have put them on treatment, whether they are adherent. So once the plan is there, it will be followed.
All recorded, all registered,
and reported
get
on.
the data. Yeah.
Yes.
Yeah.
But if it's not there, they will say things are okay, things are okay, not receiving the
Joel, thank you for giving us that brutally honest picture in Uganda. Which brings us to Monique of the World Bank. Now, look, I know the World Bank is involved in many different initiatives and programs. What is the World Bank's view on standalone national action plans for cardiovascular disease?
Well, first of all, really happy to be here and very important discussion. And I don't think this should be a yes or no about the plan, but I'll give you a little bit on our perspective on plans, but then maybe move broader and build on what Lillian was saying about the UHC agenda and how this links into the financing. But we're not big fans of very specific disease-specific plans. There are very many disease-specific plans that are completely unfunded. And so developing plans doesn't mean that there's funding or implementation behind those plans. Having said that, it is really important to recognize that the way disease patterns have evolved over the last 20 years, we're looking at a totally different situation now than 20 years ago. While our global health architecture is reflecting maybe priorities, diseases, and needs from 20 years ago. And so being aware of that, we co-hosted the NCD Financing Forum at the World Bank in June, very heavily focused on our partner countries and really coming together in preparation for the high-level meeting next year with the WHO also leading jointly with the World Bank and working with countries to really look at what does it mean in the way we plan, organize, and finance health systems with this massive transition that's happening. And we haven't talked much about that here yet, but just wanted to emphasize also the importance of aging in this. And so even in Africa, you see very rapid aging and a very dramatic increase in NCDs because of that. The impact of climate and increased temperature on the outcomes of patients with NCDs, the issue of fragility and how going in and out of fragility and war impacts the ability to treat people with long-term diseases and the costs that are associated with that, while actually overall government's financing for UHC and for health is decreasing, right? And so now, because of that, our president said he wanted to make a commitment to UHC, and as part of that, we announced that 1.5 billion people reached in 2030 in April, and that number actually is a doubling of our financing for health, and is particularly driven by expanding our primary care financing to incorporate NCDs. And so, as Gerald will say, we have traditionally funded a lot of work in primary healthcare, but we're realizing that that this disease pattern is changing, and we want to continue supporting comprehensive service delivery for priority primary healthcare package of services that requires health workers that are skilled, that are trained, that are well paid, that require supply chain, that deliver the medication and the drugs that you need to treat NCDs, etc. And so that's where our focus lies, and we will work very closely with all of our partner countries, ministries of finance and health, to help implement this and finance.
So it was interesting when Gerald was talking, and he said that a lot of international institutions weren't interested in donating for NCDs or cardiovascular disease in particular. What would you say about how LMICs can leverage innovative financing mechanisms or funding models? How can they help themselves to funnel more resources into NCDs?
Yeah, I mean, the first point of entry is to look at prevention. I think somebody already mentioned it, right? And so there are tremendous cost saving. Of course, it's also better for people, right? To prevent disease or do early detection. And so that's a really big one. And for that, we are also looking at what we can do to support our client governments on, for example, tobacco control, intake of sweet beverages, etc. So population-based measures, also change in physical exercise, etc. So that's number one. Number two is that there's a lot of funding in domestic budgets that are currently not used for the right purposes, right? And so even within the existing budgets, and this is very much part of the UHC agenda, to public financial management, but also better prioritization towards interventions that we know that really are impactful and are cost effective. We can do much more with current government budgets. And then, of course, there's also a need for more funding, and we are aware of that. We're looking at how the World Bank IDA funding for the poorest countries in the world can support this agenda, but we're also working with the private sector arm of the World Bank to look at specific investments that are complementary, for example, in local supply chains, in production of medication, etc. And so it will be sort of a package of financing tools that are needed. But I think the biggest shift is, and I'm hoping 5 years from now, if we meet Gerald again, that we say the World Bank is there to support NCDs, and in 2024 we saw a big shift, and that's what we're in the middle of making sure that our primary healthcare programs that we finance in over 100 countries that are incorporated in NCDs.
Brilliant, Monique, thank you very much indeed. And I think what I want to do now with all of you is just drill down a little bit more into the practicalities of implementing, whether it's a plan or tailored strategies towards trying to reduce cardiovascular disease. And Lily, let's pick up on what you were talking about with, actually Monique has mentioned as well, the importance of universal health coverage. Obviously, this is a big goal for the global community. What role does UHC play in delivering cardiovascular services?
Yeah, I think before I comment on that, this issue of funding for NCDs, I think for us as the civil society in Kenya, we already resigned to the fact that there is no funding coming for NCDs. I mean, based on what we can see, based on the reality, this is as we say, this is a condition that affects you, it's not a global security issue. Even if there is funding, is it going to be sustainable? How long will it be available? So we are focusing more on mobilizing domestic resources from the government.
Is that fair?
I mean, if the funding comes, it's fine. But I'm not sure we can rely on donor funding to manage anything. I'm not sure it's a good idea. So we are focusing on mobilizing domestic resources.
And I think in any case, you were saying that when there was international funding for the plans that there is money for area and HIV, when the funding dries up, that's a problem. So,
and even for those programs, they are now asking governments to put money.
yeah.
So I think that ultimately domestic financing will be the solution. That's what we are working with.
And this is the same pressure that's going to be on UHC. The money is going to come from
exactly
the same.
So like in Kenya, we are now in the deep of UHC, and we recently came up with the benefit package of the minimum package of intervention, which every Kenyan must get without incurring catastrophic financial burden.
Yeah.
So we have that package. I would say, the UNC movement was a good opportunity because what it did, we as the CBD community contributed and said, these are the interventions that should be included. Were they all included? No. Sometimes they were included, but whatever was included was not enough. Like, for example, hypertension care, they $20 per family per year.
$20 per family per year.
Yes.
Okay.
And apparently should be enough to manage dual hypertension. So you can see I'm not sure it's going to work, but at least the condition is there. So those are now, and they always say the benefit package is evolving. It's, you have to start somewhere and then continue improving. So it's up to us as the CBD community to continue providing technical advice to the government so that they can improve whatever is covered for CBD. And that's where I think the action plan would have been very good, because we were kind of caught off guard as the CBD community, because they made this package so hurriedly. By the time they reached out to us for input, it was like in the 11th hour. So if we had a CBD action plan, they would have easily gone to that plan and said, this is what we want. Yes, you get it. So I feel the
Because you'd have had the framework, you'd have had the target.
Yes, so I think in a lot of it's not optimal because again, we were kind of caught off guard. So if we had a CBD action plan, definitely we would have been way ahead when they came to us to help with the UHC package.
Yeah.
So that's why I still feel it's important to have a CBD action plan.
Okay, well, that's positive. I mean, it does sound a little bit like CBD action plans are a bit of a luxury, right? Because given everything we've talked about, the competing priorities. Sophie, okay. First of all, the arguments that we've heard, or the comments that we've heard from the other speakers are really interesting. Is there anything that they can pick up from the European action plan that might work in their context in terms of mobilizing resources and getting policymakers on their side? Because you're doing this firsthand, albeit with European governments. So what takeaways are there from that?
Yeah, I don't have any silver bullets. And of course, as Magda said, everything needs to be adapted to local context. But two very simple things from my side, and again, it's nothing new, but could be worthwhile to be reiterated. But the idea of coming together as one voice. So when you're talking to the government, you're not only talking as at this society, this organization, or this patient group, but as a whole, to show that you are there to support them. That if they decide to take this on, they're not alone. They will have a whole wealth of expertise to feed into an action plan, what is needed on the ground. So this idea of having the community approach, the one voice approach, is one thing that we hope is also making a difference slowly at the EU level. We're also not there yet with the action plan. So let's see. And then again, not something new, but again, the mindset shift that needs to happen across governments, policymakers, the idea that it is, so we are paying for cardiovascular disease anyway now, the cost of inaction and not making any changes. And you need to think of it differently in that you're investing in cardiovascular health, as it was mentioned already. You're preventing costs later on, you're preventing informal care costs and the economic loss that is seen that way. So this is something that's probably a bit universal as well.
Yeah. Yeah, it was interesting what Gerald was saying about the perception of NCDs as a lifestyle disease, as something that perhaps isn't as urgent to take care of as communicable disease. Is that prevalent in Europe as well?
Yes. Yeah, I think there can be, it's seen a bit more silence and it gets a bit of a negative press when you think of diabetes, obesity, cardiovascular. They can be lumped together into a personal problem. And it is the same at EU level that we are tackling against this perception, and we need action across the board on primary prevention to rehabilitation, but even at primary prevention level to move away from putting blame and responsibility on individual, but in the EU, for example, having more better action on tobacco control, environmental policy. Yeah. There are things that governments can do at primary prevention level that
I want to mention that in Kenya, cancer, which is an NCT, has a very different. It has an emotive.
Yeah, I was gonna want.
And we also have politicians in Kenya who had cancer. So based on that, cancer is way ahead.
Oh, surely there must be politicians with cardiovascular
I
disease.
don't know why they have to come forward, but the ones with cancer is very public. And because of that, cancer has even it has a Cancer Control Act. It has many more policies. It even has government institutions too, the National Cancer Control Program and the National NCI. Yeah, there are two bodies which are charged with policy development, implementation, monitoring, and they are even funded. So cancer took a very different trajectory. There was more funding. In addition,
I mean, cancer has got
Yes,
massive
it has more.
advocacy
Yeah.
groups,
And
really pushing heavily
exactly,
to.
and there are more society strength and more patient voices. So cancer for us has had a very different,
Yeah.
and maybe we can have, I know the funding.
But also cancer, the international community is interested in research, in cancer. So they do some support compared to the CTVs. The international community supports cancer research
Than CBD research. Yeah, that's astonishing. So Gerald, then, I mean, I suppose the nitty gritty question is how you get your Ministry of Health, how do you get policymakers to look at a CBD plan or make that plan, develop it, implement it, set the targets, set the quantifiable measurements. What would it take? I mean, are we looking at multi-sectoral collaboration? If international donation is out of the picture, then what is there? What's left?
Thank you. First of all, our government listened to WHO guidance. WHO has not come up to emphasize.
Interesting.
Emphasizes NCD plan, but sector NCD plan,
Right.
where different sectors come together, learn together for NCD plan. So unless we have a buy-in from WHO, the governments may not listen.
That's a shame we don't have some from the WHO.
But we do encourage NCD by sector. Sometimes they put some funding to process, to develop NCD by sector. And also what we can do, if the international community or partners would provide initial funding in developing this plan.
Yeah.
And also some implementation of research and policy beliefs to convince the policy maker this is the way to go. Justify why we need a standalone CBD plan, and also show how possible it is, how cost effective it is. Is it manageable? Because our people like listen, how much will it cost? How much does it take? Because as my sister said, the cake is small and we have to share many priorities, including political priorities. So I think what we can do to make this one, make the CBD standalone plan to work in lower income. First of all, buying from the region. Also, some data to show that this is possible, this is not so expensive, this is possible within the maybe domestic resources with some support from partners. But also, whether this cannot be packaged into the universal health coverage, because now what our policy makers
Right.
Yeah.
So,
how that is coming through.
can I just ask you quickly, because William made the point that maybe there would be more pressure if it was an African organization like the Europe Alliance that could bring to bear more pressure on regional leaders.
Yeah, the regional organizations are there. We have CDC.
Yeah.
But because of the pressure for the community organization.
I was going to say, the African community is very much focused on community. I mean, AMR is a huge
Huge issue for them at the moment.
Yeah.
Because of that pressure. Well, it will take time to this one,
Yeah.
make a case for CD with standalone. But we do have civil society, we have NCD Alliance, it's a NCD Alliance. We organize that, no?
Yeah.
So that they put pressure on them.
But again, that's NCD wide, rather than,
Yeah, that's NCD.
Yeah. okay.
Can I ask you something without funding? I think one would be, if we bring together the civil society and vision. I don't think CBD has a strong coalition of civil society and business policy.
Yeah.
I think
We'll talk
for
about
Kenya,
that.
I think that might be a good way of starting to put pressure to development. We haven't done that, so that's something we can do with not much funding. Secondly, I think technical support by itself from people like World Health Federations to countries can also help. So sometimes we are like, want to do a CBD action plan, where is stuff? But if we get support from World Health Federation or other, you know, even it could even be,
World
it could
Health
be,
Federation's taking note.
it could even be
Down at the bottom there.
it could be even among ourselves in the
Yeah.
atom,
Yeah,
come together and see how we can. work.
Yeah, so technical support would be
So they don't support themselves, which is
absolutely,
really useful.
And that's what happened with the malaria and HIV action plans. We are supporting. But lots of resources
and the technical support, and that's what we need to do. Okay, that's. I'm gonna, I definitely want to talk to you about civil society. I just want a quick word with Monica about, we've heard a lot about universal health program. This is something that World Bank, is very actively, involved in. So, what role can the World Bank play then in, supporting UHC programs for, low and middle income countries?
and I think, in the case of Kenya, Lillian described it so clearly that the privatization process is really important, right? So to have people with the competence and the knowledge on NCDs at the table when decisions are being made, right, is incredibly important. And in Kenya, our health portfolio to World Bank, that financing is for service delivery to health insurance, the primary healthcare package, and that includes NCDs, right? And so countries can use the funding from the World Bank, right, when they prioritize NCDs as part of their package. And so when we say there's no funding, it's not true, right? There is funding available, and the domestic part is incredibly important, not to get the same dependence as with some of the other diseases. But we are talking about there's not going to be a vertical fund with grant money for NCDs. That I think is right, that there is not going to be, and maybe there's also benefit to that. As from the start, there's more ownership and country leadership over this agenda. And then funding, like the World Bank funding and other partners like the Regional African Development Bank, that is funding that is on budget, it's owned by the government, right, and designed by the government on the basis of this kind of prioritization process, then funds the priorities in the primary healthcare package. And in the end, you have to imagine, and it goes in the field very often, it's one facility with two health providers, right? And they treat the child with malaria, and they also treat the adult with hypertension, right? And they treat the person with diabetes, etc. It's all the same person, right? It's not a different person. And so if we build capacity there in that platform, in that rural area or in the city, really addressing the needs also of poor people, then we're going in the right direction, really strengthening the system to incorporate NCDs in the guidance.
Okay, but not specifically cardiovascular.
Then we go down the same road. Like, okay, we're only going to go in with a plan for cardiovascular disease, not diabetes or cancer, but cardiovascular disease. And how is this going to work in collaboration?
But Sharon was saying that, Lillian was saying that when it comes to plans for malaria and HIV and communicable diseases, those plans are set up with specifications, with measurable targets, because that is really useful. Why can't we have that?
That is useful because those plans are then matched with funding from a vertical initiative that puts the funding towards those plans. But you can plan for an NCD plan, but if nobody comes with the vertical financing for that plan, what are you going to do? Right? And that is not going to happen, right? And so what needs to happen now is to use funding that is for primary healthcare or system strengthening to make it work for the NCD agenda. And then really monitor that and be honest, right? Look, in every year in Kenya, are we making progress on hypertension? Are there more people that are having treatment for hypertension, etc. But if you are sitting there waiting for the vertical fund for NCDs to fund your plan, it's not going to happen. Right?
But if you do the activity action plan, then you have to link it with a funded program, like the UHC.
Yeah.
So we can still do the activity plan, but having, so the UHC initiative is already supported. Have a strong linkage with programs which are being supported by government and financed.
Yeah. Link it to initiatives.
Exactly.
programs, Chart.
It has to be financing and implement whatever plan you're doing. So whether it has to be linked to some financing mechanism.
Okay, thank you for that. So Magda, we've heard a lot about the power of civil society and how civil society can put pressure on governments, on policymakers, and help bring about these changes. So we're not just talking about patients, we're talking about entire groups, advocacy groups. We've seen what they've done for cancer. In your view, how important is it to get those voices heard, and what difference can they make?
I was patiently waiting to answer, because ultimately, who's gonna be affected by successful implementation or lack of it? Us. Can we just stop creating the wall between us and the patient, or us and them? It is us. Sooner or later, it will be me, you, your child, your mother, your father. Sooner or later, you will be in the hospital, or your parent will be in the hospital, and you will become an informal caregiver. One of you said earlier, which really stuck with me, that today is the reality that we planned 20 years ago. Today is the reality we shaped 20 years ago. What reality are we shaping for the next 20 years? Today, what are we shaping? I struggle to listen patiently that reason for death, regardless of where you are, is cardiovascular disease. Whether it's hypertension, whether it's as a result of familial hypercholesterolemia or anything else, does not get the attention it deserves because it needs to hook up with something else. I kind of heard saying that, we need to link it to maybe health system resilience or cancer or something. So what has COVID proved to us is that people with pre-existing cardiovascular diseases were the ones who were paying the highest price in COVID because they were the high-risk group. So why are we still talking about non-communicable and communicable? If you have cancer, you probably will have CVD sooner or later. If you have CVD, you probably will develop diabetes or kidney disease. I think what Sophie was saying, and I really appreciate it, and I would like everyone to hear here, is that unfortunately there are comorbidities, and sooner or later we will be affected one or the other as a result of existing therapeutical intervention or something else. So I just felt passionate to take it out of the system and just think, we either talk about disease or health. That's one thing. And we talk about expenditure and cost. How about if we could turn it around and actually, what if a plan could help us make money? Okay, so let's imagine a world where actually having a cardiovascular health, not disease plan would help us make money. And patient organization, civil society, we actually took it upon ourselves that as long as we are not empowered to talk data, do research, talk the same language as decision makers, we won't be taken seriously. So we did research, and we have proven cost effectiveness of some early interventions. Early detection of some of the genetic pre-existing conditions, like in this particular case, FH, can reap dividends. $1 spent on screening and prevention will reap dividends of $8 in return on investment. This will also prevent a heart attack. This will also not take the 40-year-old John or Sally out of the workforce when we are actually facing an aging population. We cannot, as a society, as a civilization, allow for the peak performing group to be suffering from a heart attack, stroke, hypertension, and so on and so forth. So I just wanted to say, how about if we try to change, turn the narrative around? And we already feel that in Europe. So what countries with lower middle income should say or learn is, let's not go down that pathway. Let's learn before it's too late. Yeah. And I was happy to hear you say the WHO, you follow WHO because there's a lot on CBD from 25 years ago on CBD. That said, there's a famous saying from the AIDS community, nothing about us without us. If we want to design an answer, we need to design the answer together with the user. End user is the patient. But how about, and I know that we have in the audience some people from the medical universities. So, what is discussed here today will affect you and your kids probably. So you need to be at the table. You need to shape the future you want to be then. And I can tell you that anyone who has had a heart attack or stroke, 7 stents, bypasses, or a 9-year-old with 3 open heart operations, if given a second chance, will say, yeah, why not? I'll go do it again. No, nobody wants that.
Yeah.
I told you that I can speak passionately about it, but you haven't stopped me.
But I just want to follow up about what I said about the WHO. Now the WHO is funding and encouraging NCD investment cases. If you invest $1 in NCD prevention,
Yeah.
investment. It's not talking about NCD, CBD standalone. That okay, or you think we should pull out NCD from the NCD investment case?
I represent specifically a community with familial hyperlipidemia. There are 4 conditions. We represent grosso modo 1.6 billion people around the world. It's not enough for some to be a standalone, even though we actually have a lot of successes in influencing policy, and I haven't necessarily even talked about it. So we've made a decision that we need to come under CBD to unite, because then once we have the plan, we can probably be more effective. Now, I don't think I'm the right person to say with or without NCD. What I'm saying is that sooner or later you will see the benefits of health. So if you do something well and right in one area, health will affect all of us. And health starts from the kitchen table. How you think about it, what you eat, how much you move. Let's not look for grand ideas. It's unfortunately some of the solutions are very, very basic and fundamental.
Simple, very effective, very effective.
Oh, well, not for everyone. I appreciate it, but there's a lot we can do already.
Things we can talk about that.
So, yes, please.
And short to this really interesting point in the review, also had this debate back and forth intensely recently, NCD plan, CBD plan. And the NCD plan is absolutely a great place to start. We do need that as well. There's, of course, biologically so many interlinkages between the diseases. So, of course, it makes sense primarily looking at primary prevention of these baseline diseases. But then you follow the patient, Magda can speak better to this than me, but you see how different care is needed. To care for someone after a stroke, it's entirely different to a CP patient receiving dialysis 3 times a week. So there's clear rationale for our argument for specific plan, because the needs are very different once you go beyond primary prevention.
That of course was the national cancer, the argument for national cancer plans as well, which I've seen quite a lot of take up. Okay, I'm gonna throw it open to the
Can I say one more thing?
yeah, I think this whole dichotomy about the plan, and what really matters is that we see implementation programs, right? And so I mean, let's talk about that, right? And then I think, okay, the last time I was in CAR, right, the Minister of Health tells me I have $7 per capita for my whole health. Right? Nobody there ever gets to open heart surgery, ever, whether they need it or not, right? And I can't even provide the absolute basis, right? And so that's the complexity we deal with, right? And can we then invest in a health system in a way that at least it can take on a little bit more, right? And go a little bit further and push that so it can influence NCD, right? And I think that is our challenge, whether we have a plan, another plan, or we have that. I mean, okay, right? But, a year from now, 2 years from now, 3 years from now, next time I go to CR, is there any progress there?
Yeah.
Right? Or I go visit Gerald in Uganda and, he has made a little bit of progress and suddenly people are a little bit more interested in what he's doing. And so, but that's what we're up against, right?
Okay.
And
So look, we've all spoken about the high level meetings. I just quickly want to go around and ask you guys what your thoughts are. And I do mean very quickly because I can see we've got some interest from the audience. UN high level meeting next year on NCDs, but what a national cardiovascular plan is one of the commitments that we're hoping to see from member states. What do you want to see come out of the high level meeting next year? Shall we start with, let's start with Uganda.
Thank you very much. As many speakers have said, we're not likely to see practical findings from NCD. But I would expect some practical solution of innovative finding of this effect. These leaders will come up with how best can we find NCD for the development goals. The way things are now, they are not okay. So these leaders, when they meet, they should tell us how best are we going to find NCD for the development goals. Simple strategy that I say, in the temple and how we exercise them, but it costs money. For example, in Uganda, if you have this, you are more respected than a family. Really not. You even fancy names when you have this. You give the front seat, not give more food actually. You become more of this. So how do we get funding? Yes. That's what I expect.
Thank you, Gerald. Lily, what do you want to see?
They need to put more money to us. I don't think we will get more funding for this. Find the health budget remains as more as it is. So I think commitment was just increasing the health budget will help us down the line. And at the same, innovative financing for NCD.
Thank you. Sophie.
Yeah, I agree, of course, and I think just as it started to end the same way, to have a plan, I think it is important. You won't get to implementation without starting from a plan, so to have that commitment, following the patient pathway, and in particular pursuing research and for data registries, that's something that the European Society of Cardiology.
Thank you. Wait.
implementation.
So we already are implementing. We are actually, patients and citizens are tired of talking. They want to see doing, and that's what we took it upon ourselves. We go one country by one. We go for early screening detection, country at a time. Croatia, Slovenia, the Netherlands, fighting for France, one by one, because we believe that the money you invest in health will reap dividends. So it's this we need to stop thinking about disease only. We need to start thinking about investment in health on multiple levels.
Brilliant. Speakers, thank you very much indeed for that. Now, I really want to get your thoughts. So why don't we start with gentleman at the end?
The lead answer from Ross, but I mean, I'm so happy I came to this and didn't go to the. I think it's been really, really super interesting. And I think it's just listening to NCD plans are very important. Yes, but I think Europe showed the way by taking a look at the key morbidity and mortality. So you have the EU beating cancer plan. It'd be fantastic if we then went and read the CBD plan. Because when you look at governments, they see NCDs and they just see this huge thing. And you can put a little bit part of funding into it. But again, what do you actually get out of it? It was actually a World Heart Federation event at the WHO this year, where Denton Nicholson spoke about the UN high-level meeting on NCDs next year. And she said, if you go into this with a huge agenda, you get nothing out of it. And she highlighted, for example, hypertension, something specific, something measurable. And I think that's where it needs to go. So it's almost like, does the NCD umbrella become a hurdle to actually making progress?
That's interesting. That's interesting. What are some more thoughts on that? Because as some of our speakers were saying, the WHO tends to treat NCDs as one big area. How do we drill down and should we drill down? Would that make it
So from what we know that there is at least an ambition, and I would like to be corrected by those who might be in the better know, but at least that it has been recognized that lipids as such, as CVD risk factor, are important. And there is a creation dedicated to, there's going to be created, I'm being lost, sorry. There's going to be created a dedicated lipids task force within WHO to tackle that.
There is.
There's an addition and well, that's what I heard from Geneva resources from.
Well, is that because of pressure from?
I think it has been realized now that you have to be specific, and it has been forgotten for many years.
Okay. Yeah, but I mean, that's progress.
There's progress, but it needs to again build on expertise and experience we already have of what works, what doesn't work, and how to do it. And, in preparation to those questions, I was thinking, we cannot miss the ultimate end user at the table because all the solutions are being designed by a lot of people talking about the recipe. But then we need to be as well able to identify the gaps in the system and the opportunities in the system. Because there's only so much money, there's only so much time, and we really need to be careful how we invest it and how we spend it. So it really is effective.
For institutions like the World Bank, possibly less attractive, looking at tiny aspects of NCDs. I don't know if put words into your mouth. Is it easier to talk about investment across the spectrum of NCDs?
I think the beauty of partnership is that we each bring our complementary advantage, right? And so we have a big program financing the health insurance program in Kenya, and that is comprehensive of all. So women that are dying in childbirth also need to have access to services, and that dichotomy and challenge, right? And Lilian spoke about it, and you as well, about the choices that countries have to make. And I do think that they're probably very different challenges. When I look at Latin America, for example, the work we do in Eastern Europe, these health systems are in a different stage of development, right? And so I think we need to be careful not to all put it in one pot, right? And it's just not the case. And just say about, because we work very closely with WHO, our joint hosted event in June was part of the steps towards next year. And sadly, Bente, who's a very good friend, retired last week, which is a huge loss for us. But she's, around and as an advisor and all that, and she's fabulous, and I learned a lot from her. But I do agree with her that being specific is going to be very, very important in that. And you saw it this year in the AMR meeting, right? And so it's sort of this one moment, the international community puts a limelight on it, and we should take full advantage of it.
Thank you. Any other, loads. Okay, lady,
thank you. Pernilla Gunther, in this special meeting, I'm representing the European Commission. I'm a part of the Cancer Mission Board, who are ambassadors for implementing the European Cancer Plan, and also together with the Horizon program and the projects and funding from that. And I think it's very interesting sometimes because I've been involved in CVDs for a long time also before I started working with cancer, that we have so many similarities. So I think, and that's also a personal ambassador for that we should also take advantage of the learnings from the European Cancer Plan. I mean, we have these goals, understanding, prevention, diagnostics and treatments, and quality of life. I think that's quite easy to really implement for cardiovascular disease as well. And I'm also very fond of the fact that we should be able to compare and see where the similarities are and the results also. I mean, lifestyle factors, for example, is quite the same for both CVDs and cancer. And also if we put cancer and CVDs as the big headlines within NCDs, then we can put all the other NCDs mentioned, not only for Europe, but also for the World Health Organization. I mean, under these two, we can also see all the comorbidities that Magdalena mentioned, not at least, that will affect us all. So, I think sometimes we are competing with ourselves, and I don't
Yeah.
think we will reach any good results from that.
That's interesting. Well, Sophie, parallels to National Cancer Plan?
No, yeah, I completely agree with what both comments so far. It's about being sensible, rational, and learning from practices that have already been successful, not duplicating
Yeah,
their own
that's fair enough.
Yes.
So are you one of the young medics?
With like, well, I mean, first of all, sorry, like my voice is a bit quacky. At the minute I landed in Berlin and just became sick. I'm very,
Lovely, am I all sitting here? Hope it's not communicable.
no, I'm Javier from Morocco. I'm here on behalf of the International Federation of Medical Students Association. My role within the organization is lesion of public health issues. We do work on NCDs and other, also the communicable diseases and everything. So we just want to reflect on what has been said. We do think that NCDs are very important, you know, and we are like in the past 10 or 15 years, we have been shifted from communicable acute diseases that are very fast to treat to non-communicable diseases that are chronic, affecting not only the individual, but also their families, their, you know, socio-economic life. You know, imagine like the head of the house is sick. All of the houses, you know, scrambles. So it is affecting other people. And we do believe that preventing diseases is much more cost effective than, you know, treating the disease as they come. So we need to work on prevention as much as possible. And I just want to like add like a point of recommendation about like the lack of funding, because it's an issue with like most of like the middle income countries. But what I want to say is that have you thought of maybe strategies to reach out to communities, educate communities, to then transmit the knowledge? Because they are like most of the STDs are, you know, preventable. So if we like adopt a healthy lifestyle, if we adopt like good like habits, then maybe we can like have a huge percentage of like those like, you know, prevent those like chronicity of diseases. So I don't know if you have thought of that and if you found any challenges, maybe reaching out to communities, reaching out to students, to like local communities, educating them, maybe involving experts to educate those people, then those people then can educate other people and reach out to the communities. You can prevent a lot of
They
people.
have thought of that, but doing it
Yeah,
in practice.
it's cost money. It's cost money, but you.
But even if you've got like the schools department involved, you can't. Surely this would be a
Everything
cheap
is safe.
way of educating.
Everything is said is in our strategic plan. Use schools, use churches, you know, actually our curriculum, our school curriculum has really put in a lot of health eating and physical activity. Currently, that is that happening to the young children. And, but even mass media messages about healthy physical activity, diet, all that is in the strategy. So I think it's getting it out.
And it's cross-cutting, it's cross
And
retail,
it's our need, therefore,
food industry.
there's a funding element.
In Uganda, we have some researchers trying to use adolescents as the message in the family. We are waiting for the results. They train the adolescents, discuss with the adolescents about mainly the healthy eating and physical activity.
Yeah.
Then following up and see whether they will influence their family.
I'm very influenced by my teenage knowledge. I think it would be effective.
I am so delighted that you're in the room. The patient community conducted unique research in 2020. We reached out to an online 2 million people big community of medical students and early doctors all across all indications. And we did a very simple survey, 6 questions about the most common condition, genetic condition in the CBD risk factor. Less than 50% of people responded correctly. We had 111,000 respondents from around the world, which demonstrates that when we talk about education, we need to think about who are we targeting. So medical community today, when you ask how much time you were taught about prevention, is equal to 0. But current medical curriculum has no prevention in it. So if we want to start educating families and children, we need to recognize that when we flew here on the plane, We were not offered healthy eating, but we were offered tobacco at a better price. When you go to a school canteen, you are offered deep fried food with Coca-Cola. When you are shopping with your family, the last thing just before the till is gummy bears packed with sugar and artificial food. And kids have no longer cooking classes and they're being dispensed from physical activity. Now, in middle and low-income countries, because the progress of some of the development is maybe not yet so far, people still walk, cycle, or maybe eat different food. So I think we need to recognize that we need to go back to the grassroots. What used to be obvious to me when I was a kid, that you eat, run, and do other things, but at the same time, we need to catch up with educating the force, the medical force.
But I think
Prevention
there's
and
more
all.
awareness of it. I think there is one. Yes. Vivian.
Hi, I'm Tasmin Khan. I'm Senior Manager for Health at the Africa Europe Foundation. But I know most of you from my old hat, which was the Cardiovascular Advisor at the WHO. Now I get to say things that I want to say. Not that I'll taxation. But the fundamental thing is that there's no narrative in this space. I am an undergraduate medical doctor from South Africa, and I specialized in something called community medicine. So I'm actually a medical public health specialist. And my career started in communicable diseases. Why? Because traditional public health was surrounded around communicable diseases. I did surveillance for outbreaks and I did pathogens because those were the two things that were fundamentally public health. What is absent from the NCD agenda for the past 11 years I've spent exclusive in NCDs is that there is no narrative. There is no public health narrative. The cardiovascular burden is driven by cardiologists. The cancer burden is driven by oncologists. Whereas HIV, TB were driven by a team, infectious disease specialists, public health specialists, non-medical specialists, prevention specialists. You had all different players in the field. That is not how the non-communicable diseases are. It's because the etiology of the disease is very different. I personally don't agree with the NCD term. The diseases are too heterogeneous. They're across different levels of care. They require completely different capacities and personnel to drive them. And I have a similar opinion about domestic financing. It's nice to talk about domestic financing, but most countries are experiencing debt that is insurmountable and do not have the fiscal space to increase their funding. So it's a nice narrative, but it's very difficult to implement on the ground. The fact is that the cardiovascular disease burden has some low-hanging fruits. There are things there that influence mortality that will get you to the SDG. You cannot say that for all NCDs. And also, there's a lot of confusion about what actually constitutes NCDs. Because when you learn traditional health, you don't learn of this term called non-communicable diseases. You learn about infectious and non-infectious. Things like thyroid diseases, bone disorders, everything falls under non-communicable diseases. I personally think there's value in having a cardiovascular disease plan, provided that it can get the political will to go behind it. Without the political will and without some sort of financing, no plan at any level, whether you call it NCD or CBD or anything else, actually going to work. But I do think that one of the most cost-effective interventions and driving equity would be treating things like hypertension. Now, the other problem is that in the NCD community, we are very keen on prevention, and that's because there's a nice narrative in prevention. I worked on public policy in South Africa for a long time. I like the narrative. I like the idea that environments play a role, that public policy, regulation, fiscal policy all connect. That makes sense, that's a narrative. But in the area of management and in the area of health system services, that narrative for NCDs doesn't exist. And this is why you get governments very confused. Should they invest in childhood cancer, chronic obstructive pulmonary disease, hypertension control, congenital heart disease, pulmonary thrombosis? The field is endless. There's no clear narrative. Start with something, build on it, and move from it. Even at the PHC level, there's been no evaluations to show that integrated care for the NCDs actually has sustainable impact in the health system. There's been no evaluation showing that things like PEN have shifted the mark, have improved health outcomes or mortality. As you were saying, we need measurable outcomes and we need to move the narrative and build it. And I do think the UN high-level meeting is a chance to build that narrative, but I don't think you can throw everything at the kitchen sink in it.
Thank you. Great comment. Thank you very much indeed for that. Look, we are coming to the end. Greg, did you have a comment?
Yeah, well, I'm gonna speak.
We'll make this the last
Yeah.
one, guys.
Actually, what I want to do, I like this concept of rust. Well, but it's not like patient consumable ads. And I was trying to think over loads of notes here. So, okay, let me look at this from an us perspective. I listed here, system normal hypertension, brother with diabetes is cancer. Myself, my best friend, my father-in-law, sleep apnea. And my daughter has lipidemia, which is the growth in the legs, yeah? None of us were self-aware. None of us were aware that these things were going to happen until very late stage, yeah? And I think what I want to emphasize, and you started, is that self-awareness. That people can be taught all about eating properly, running, whatever it is. I actually think as I was a kid, we were taught. Growing up in the UK, you had sweet life. Okay, and I could go on that. I think there's something about teaching people self-awareness, not about multiple countries, but be aware about what you could have. I didn't know I had sleep apnea for about 10 years afterwards. Could have died from a heart attack. My brother didn't know he had diabetes until a very late stage. Yeah. My daughter didn't know it was lipidemia. She thought she was putting weight on, couldn't understand why she was okay here, but her legs kept growing. Yeah. And my sister didn't know any of that. Well, and I'm coming from the UK. Yeah. Europe. So I think self-awareness is something you probably have to think. And I like the concept of us. We're all patients somewhere. Okay.
Let's start.
The medical student, she has been putting
Yeah, go on then.
Just a quick question. I'm Hannah, I'm a doctor for medical education issues and working in the area of professional education and international federation of medical associations. So basically the question that we have, I think something that we all agreed on during this panel is the importance of partnership when it comes to addressing these kind of issues and what all of us and different stakeholders with different perspectives can bring to the table. So maybe the quick question for the panelists would be if they could quickly reflect on what do you think, like how medical students, especially medical student organizations, for example, on local, national, or international level, can support you better and how they can engage and collaborate with you when it comes to addressing this stuff. Are you ready for the list? There's plenty, from co-designing awareness and education to going out proactively to the community. Because we know that in Turkey, if you want to talk to someone about genetic CVD risk factors, you go through Iman. If you are in Romania, you go to the hairdresser. Those are key opinion leaders in the community, like not your journals, nor your peer review journals that nobody knows they exist.
And TikTok.
And so that's why we get evidence to start influencing by influencing with the language, the messages that resonate and helping fix the lack of awareness and health literacy. Whether we like the terminology health literacy or not, doesn't matter. There's so much we can do. And you guys are in millions on the ground is going to help change it.
No pressure. Just change it.
Let me add one thing there on the prevention side. I really see you as part of the generation that the medical system to be much more aware, inclusive, et cetera, around the prevention side and not just think on the curative part, and that would mean a massive shift. But yeah, that's a very good point. Yes.
Also, yeah, I think it's, I mean, when I was working with the Kenya Cardiac Society, we did work with the medical students during health campaigns, and they would help us a lot in investigation, screening. Definitely there are opportunities.
That has been a really great discussion, and we are over time, which is always a good sign of brilliant, thought-provoking and wide-ranging discussion. Candice, thank you so much indeed for that, and thank you for your questions. It is time to take a break, to network, to relax, to prepare for tomorrow. But first, please join me in thanking our fantastic